And now I'd like to welcome Tim Frond from Banner Health to give us opioid safety and Narcan safety training.
Hello, my name is Tim Freund. I am a parent of two scholars that go to the Great Hearts Academies, and I've been asked to come in today and speak about Narcan training, or more specifically, recognition and response of opioid emergencies for school staff and coaches. And just to give you a little bit of background on myself, I've been a paramedic for over 20 years. I work in a hospital, and I work with a lot of law enforcement agencies, fire and EMS agencies, doing a lot of outreach education. So between Narcan training for schools, Stop the Bleed, CPR, you may see me again in the future, or you may have seen me in the past. But I thank you for the opportunity to come in here and speak to you all about Narcan and the response to opioid emergencies. The objectives of my presentation is to learn about the background of the opioid epidemic in America. And this is not something that's new. It has been continuing to grow over the last several years. I have some interesting graphs that I can show you as we go through this presentation. We are going to review the adapted content for Narcan training for law enforcement as issued by the Arizona Department of Health Services and the Arizona Department of Peace Officer Standards for Training. So AZ Post or AZDHS, as I may refer to them. So essentially, you are getting the same training that law enforcement officers and EMTs are receiving. And I blatantly used these very same slides because it's very straightforward and very relevant. As we go through both of the presentations, we're going to list the signs and symptoms of opioid or narcotic overdose, and we're going to explain how naloxone or Narcan works. I will interchangeably use the terms Narcan and naloxone because they are the same thing. One is just a brand name, the other one is a trade name. We will go through the course and demonstrate the routes of administration for naloxone or Narcan. There are two primary routes of administration that are available to Good Samaritans and bystanders and trained health staff or coaches, which are different than what a paramedic might do on a scene. We will have a few scenarios so we can get some real-world application or learning to this, and I will provide you lots of references and links for ongoing education so you can stay up to date on what is happening with the opioid epidemic in America. So the first question we have to ask is, are opioids really a problem in the United States? And as we look at this slide, it's a beautiful slide of the United States with a variety of different pills on here to represent what the United States looks like. And this is all quoted from the CDC, but there are over 130 Americans who die each day from an opioid overdose. This includes prescription drugs as well as illicit drugs or opioids. There's over 1,000 people every day who seek treatment in hospitals or who require treatment from opioid overdoses, but as you can see, most of them survive their encounter. So it is a problem in the United States. The drug overdoses have increased. If you go back to 1999, you can track the different types of drugs and the drug overdoses, and you can see a very sharp increase in the amount of overdoses from synthetic opioids other than methadone. And I'm using this term opioid. We'll get to the definition in just a few minutes. But another disturbing note is the sharp increase in the availability of heroin and how we've had an increase in the number of people who are overdosing on that. The other medications on here include natural and synthetic opioids or semi-synthetic opioids, which has had a steady increase. There's cocaine, there's methamphetamines, and there's methadone, which again are kind of holding still. But if we actually look at some of the statistics, there's been a huge increase in the synthetic opioid business, including fentanyl. As I looked at some references and materials that were made available to me for this presentation, I saw that AZDHS and the Maricopa County of Public Health, they referenced that some of the common medications that are prescribed for pain management include oxycodone under the names Oxycontin, Percodan, and Percocet. There's another medication called hydrocodone, which goes by the names of Vicodin, Lortab, and Lorcet. Diphenyloxylate, which goes by the name of Cadian or Avinza or MS Cotton. Codeine, which might be a little bit familiar to you from cough medicine. Fentanyl or a Duragesic patch. Propoxyphene. Darvon is another name for propoxyphene. The last three medications here are not as commonly administered for pain because they're very, very potent and they have very significant side effects. But hydromorphone, also known as Dilaudid, meperidine or Demerol, and methadone itself is a medication used to help wean people from opioid addictions, but it does have an effect where you could overdose on it, causing respiratory depression. So there are a lot of stereotypes out there about opioid overdoses. Yes, it's people who come from lower income or poor socioeconomic status, or they had parents that didn't care for them, or they were neglected, but I'm here to tell you that's not true. On the screen, you see a picture of a few famous people like Prince, like Heath Ledger, and then even there's another picture showing a 4-year-old who died of an opioid overdose. Most of the time when a young child overdoses, it's not an intentional act, it's either an accidental or neglectful act. But these kids can be well cared for, you can be very famous or popular, and you can still have problems with addiction to opioids. More relevantly, I switched the slide to show a picture from the Los Angeles Angels who overdosed on opioids because of some of the pain from the injuries that he was enduring as he played professional sports. He ended up overdosing on fentanyl. I show a picture of the gentleman from Glee. I'm sorry, I don't know. I think his name was Corey Monteith. But again, very popular, very successful, but had problems with opioids and ended up having a fatal encounter. So does naloxone or Narcan belong in schools? And I have 3 different references here that say yes, it does. From the National Association of School Nurses, from a USA Today position paper, and even from local Fox News, referencing back to a local pitcher, a high school pitcher who overdosed on fentanyl in the last 2 years. So it's not just Arizona's problem. This is a nationwide epidemic. And in Maryland, their schools started stocking the anti-overdose drug to combat the opioid use on campuses. In Ohio, after Akron's public schools had record numbers of overdoses, they started stocking this opioid antidote. So as we move into this, it's hard to identify who's going to be susceptible to opioids and the addiction. So there are a few risk factors that we want to go over. Like participants in high injury sports like football and wrestling have an increased risk of opioids recreationally. More often than not, it's male athletes who are at greater risk than female athletes for both medical and recreational use of prescription opioids. What we found is that if you play 3 or more sports, you are 3 times more likely to be approached to give or sell opioid medications. And athletes who are at greater risk to engage in recreational use of opioids because of the physical and emotional stresses associated with high competition levels. So these are some of the risk factors. As coaches and as school staff and even as parents, there are some behavioral and social signs of narcotic abuse or misuse. Typically, you will see an increased level of drowsiness. It sounds kind of oxymoronic, but an increased level of drowsiness, increased isolation, more frequent problems in schools, and increased secrecy. There will be greater irritability and mood swings. There is more agitation and restlessness in the morning, which is hard to diagnose in most teenage children. And there are increased problems with self-control. Again, another double-edged sword with teenagers. There will be decreases in their self-esteem. You may notice changes in their appearance, in their hygiene, in their concentration and their motivation to get things done. And again, a challenge as you deal with high school and middle school athletes, but their dependability decreases. So looking at some legal references, because it's important to understand this as well, Arizona Revised Statute 36-2267 states that a person may administer an opioid agonist that is prescribed or dispensed pursuant to other statutes in accordance with specific protocols as supervised in their training by either a physician, a nurse practitioner, pharmacist, or other health professional, and that you are getting this training in good for how to respond to opioid overdoses. When you administer an opioid, you are protected by good faith or Good Samaritan laws, as long as you are doing so without any expectation of additional compensation, and you are not doing so in any way that you intentionally harm the person. Accidental harm does occur from time to time. As we discussed the routes of administration, people may end up with bloody noses or with needle sticks. However, as long as you are not grossly negligent, you are protected under Good Samaritan statutes. And basically, the definition of a person in this statute is any employee of a school district or charter school who is acting in the person's official capacity. So if you are on staff and you elect to use naloxone or Narcan for an opioid, you are protected as long as you do not do so with gross negligence. Great Hearts Academies has a policy, or is rolling out a policy, that states that it requires all nurses, health staff, and head coaches to be trained in the administration of opioid antagonists by July of 2020. And the department, in coordination with the Arizona Peace Officer Standards and Training Board, shall develop this training module, which is why I'm using their content. And this has already been practiced and vetted with peace officers, ancillary law enforcement employees, which helps go through the identification of a person who is suffering from an opioid-related overdose and how to properly use the naloxone. So now I'm getting into the actual content from the Arizona Department of Health Services, and this is the use of naloxone by bystanders for opioid overdose. And very interestingly, in the center of the screen, there's a slide that says drug overdoses kill more people than cars, guns, and falling. And if you didn't believe it, here it is to tell you the truth. There's approximately 38,000 drug overdose deaths, which is greater than the almost 34,000 traffic deaths, greater than the almost 32,000 deaths from guns, and greater than the 27,000 deaths from falling down. So this is the quiet headline, because the car crashes and the gun violence gets a lot of the headlines, unfortunately. So the objectives of the AZDHS program is to give you the background in the statutes, to define what naloxone is, to discuss the appropriate routes of administration, to address the training requirements, and to discuss the immunity that you are afforded. As I mentioned, this is a nationwide epidemic because drug overdose is the leading cause of unintentional death in America. And these opioids include legal prescription drugs, which you may have for injuries or after a surgery or something else, but it also includes illegal drugs. And more disturbingly is more young adults and teens in Arizona are using heroin than ever before. As a matter of fact, looking at a statistic from 2012, there was over 41,000 fatal overdoses, and of those, 40% were attributed to opioids. So you can overdose on a lot of things, but here we're showing a slide about the number of prescription deaths going back to 2001, and you have the overall total in the blue bar, but you also have colored lines to denote the number of deaths from prescription drugs. With the orange line that's tracking across the top of the screen, these are attributed to males who are overdosing on prescription drugs, and then you can see females are about 10 to 15% behind the same frequency, but the trends are similar. As we mentioned, the increasing trend in heroin, in this graph it shows a bar in orange. So you can see how the bar has grown from 2007 to 2015. The orange bar continues to grow. The good news is, I guess, that the use of cocaine is down from 2007 through 2015. And then you have pretty consistent use of methamphetamine across the board, as well as marijuana and the custom pharmaceutical or designer drugs. That's what CPD stands for. So why are we going to use naloxone by bystanders? Because naloxone is safe for everyone to administer if they've been trained. Meaning that if you have somebody who is a known opioid addict and you are a family member, you should get trained on how to administer the naloxone in case your family member relapses. So you don't have to be a law enforcement officer, you don't have to be an EMT. Family members are protected under the Good Samaritan Clause if they administer naloxone to another family member or another person who's overdosing. But naloxone itself is very safe and effective. When I became a baby EMT in 1990, well, I shouldn't say how old I am, but this was one of the drugs that you could give early on in your training because there are very, very few side effects. And it was one of the first things you could do for somebody who was unconscious and unresponsive while you had to wait for a more highly skilled or more highly trained paramedic to show up. But the reason why there's been a huge push in putting naloxone into the hands of law enforcement and faster first responders, because when you have an opioid overdose, it is a time-sensitive emergency. Much like cardiac arrest, which can happen with an opioid overdose, when somebody stops breathing, the clock starts ticking, and after several minutes, there's irreversible brain death. So what we're trying to do is to get the person breathing again by administering this medication and preventing that brain death. So the statute that allows this to happen in the public and to first responders is Arizona Revised Statute 36-2228. And it mandates proper training for naloxone for law enforcement and EMTs and bystanders, and it allows people to, and it states that you may administer this to a person if you suspect that they're suffering from an opioid-related overdose. What's interesting is it says may. It does not say shall, should, or can. So there is an option of discretion. However, in the case of a school staff member, unless the scene is otherwise unsafe, you may administer that naloxone. This is what afforded law enforcement officers not address scene safety issues and put themselves in a bad situation. So the statute requires uniform training, which we are going through, and it requires that you identify who is suffering from an opioid-related overdose and how to use the naloxone. And it provides immunity for the physician or nurse practitioner who issued the drug or the standing order and any trained person who administers the drug. But it does not create a duty to act for law enforcement or any other first responder or bystander to administer the opioid agonist. So there are personal preservation issues at hand. It does require uniform training, so we are doing that. And it helps you identify who's suffering from an overdose versus who is just experiencing the high of a drug. And then we talk about how to actually use the naloxone. I'm going to skip through the immunity slides just a little bit because I want you to have reference to them, but understand you are immune from civil, professional, and criminal liability from any decision made, action taken, or injury that results from the administration, as long as you are acting in good faith with reasonable care. Unless you are willful or wantonly neglectful, you are immune from any prosecution. So, I've talked about opioids, and I'm going to throw another term out there, opiates. I'm going to use them interchangeably, but in essence, they are the same thing. The biggest difference is an opioid is synthetic. It's basically manufactured in a lab. An opiate is naturally derived from poppy plants. This is the primary source for heroin, which is not medicinal, and the primary source for morphine, which is medicinal. So either way, an opioid or an opiate acts as a depressant for the central nervous system and the brain function. And ultimately, it does affect, or it does act on the respiratory system as well as the cardiovascular system. But why are opiates abused? And if you've ever had surgery and you've been in excruciating pain and you take a pill and all of a sudden the pain is better and maybe you feel a little bit goofy, now you understand why people abuse opiates to get high. But the reason why they are prescribed by physicians and advanced practice providers is for pain control. So the appropriate use of opioids and opiates include pain control, and then there's some aspects of codeine and diphenyloxylate, also known as Lamodal, which can be used to relieve coughs and severe diarrhea. But the problems persist or present themselves when you are drinking a lot of Lamodal to get high. So the inappropriate use of opioids and opiates includes sharing with friends, not completing your course of treatment and saving them for later because you might fall down again, or you might have another fracture and you wouldn't want to wait. When they are diverted because you feel it's necessary to borrow somebody else's pills. And then, of course, the abuse for the euphoria of the opiate itself. So we started talking about who's at risk for opiates, and we specifically talked about athletes for a little while, but AZDHS says young adults are particularly at risk for opioid overdose because they are experimenting. They're learning. Additionally, opiate-naive people who have never been on an opiate before are at risk. If you've never taken fentanyl or if you've never taken a codeine pill or a Vicodin and you expect that pain to go away seconds after ingesting that pill, not understanding it's going to take 30 minutes to an hour for that pain to be controlled, and you take 3 or 4 more because you want it to hurry up and go away, you might overdose. Additionally, chronic users or who have been released from jail or from detox or have a history of relapse are at risk for overdose. People with chronic illnesses like cancer or chronic pain of all ages and demographics could be at risk for an opioid overdose as well. We talked about how opiates work, how they're intended to help you deal with the pain. But when too much opiate is taken, it stops your respiratory drive. It depresses your respiratory system and your central nervous system by slowing everything down. And when you decrease your level of consciousness, eventually it decreases your respiratory drive and you forget to breathe, or you stop breathing. And then when you stop breathing, it ultimately decreases your heart rate and your blood pressure. So when your respiratory drive is taken away, two things can happen. You can either vomit and aspirate, or you can not vomit and not inhale it back in. Regardless, though, you're not breathing, and that clock has started ticking. So when that clock starts, your body goes into this hypoxic or low oxygen state, and it can only survive in here for a few minutes. Then what happens is you go into a cardiac arrest state, or cardiopulmonary arrest, or a coded state. And part of the effects of opioids are increased when they are combined with alcohol, which has a warning label when you take your opiate, or benzodiazepines, sedatives, or other medications. We talked about the most commonly used ones. I'm going to put these names up here again because I want you to recognize the names, even though there are different names for them on the street, which I can't get into because I can't even keep up with them, all the different street names for them. So we talked about heroin, oxycodone and its derivatives of Percocet and Oxycontin, hydrocodone, which is the derivatives of Vicodin, Norco, and Lortab. Hydromorphone we don't see as much in the form of Dilaudid. Methadone is for opioid addiction. Morphine is very common in the medical field, as well as fentanyl. Codeine as well has its prescription practices. But the newer ones that are out there are the buprenorphone, also goes by the name of Subutex, and that is similar to methadone because it's intended to help addicts get over their addiction. The last two here on the bottom of this slide are carfentanil and sufentanil, which may have made headlines and will probably make headlines again in the future. But these are highly concentrated forms of fentanyl. So they are 100 times more potent and 1,000 times more potent than the fentanyl that's out there, which has medicinal purposes. How do people take opioids? There's a variety of different ways. I've talked about taking pills and ingesting the pills, which is very, very common, and most opioids are intended to be administered this way. Sometimes, though, when I work as a paramedic, I will administer them intravenously. I will start an IV in somebody's vein, and I will use that catheter to inject it into the vein to get the pain controlled faster. Some people, though, will take to snorting their opioids or smoking them. Some of them will inject them themselves under their skin, because one of the things that happens when I administer fentanyl to a patient who has a fracture, sometimes they get nauseated because of the rapid pain control. But if you inject it under your skin, or if they inject it under their skin, it's a slower absorption and they don't get the nausea, and the high lasts a little bit longer. So they inject it in a little pocket under their skin, sometimes between their toes or their fingers, places where you wouldn't normally see. Another method of injection or ingestion is they will stick it in their rectum, okay? And the last route, which is prescribed, is transcutaneously, meaning across your skin. So there's a version of fentanyl, which is a patch, which you place on your skin, and it adheres to it for a certain period of time, and meanwhile, your body is absorbing the medication through the skin. So why are we talking about naloxone and Narcan, and where did this come from? Well, it's not new. It was developed back in the 1960s, specifically as a reversal drug for opioids. And it emerged in the pre-hospital setting for overdose treatment way back when. So these days, there's an increased need for the Narcan because how many medications did I list a few slides ago? A lot, more than we can all remember. And there's been a problem with the prescription practices over the last several years. I'm sure you've seen in the news the lawsuits that have gone back to the pharmaceutical manufacturers. But the physicians and the healthcare industry itself is partially to blame with the liberal administration and prescription of opioids in the past. They are working to correct that, though. The mechanism of action for naloxone, it specifically blocks the effects of opioids on the brain. It does not work anywhere else but in the brain. But in the brain is where the overdose is occurring. It helps the overdosing victim to breathe again by temporarily reversing the respiratory and central nervous system depression. It should improve the person's breathing within 2 to 8 minutes. But the only bad side effect of naloxone administration is the potential for a sudden onset of withdrawal symptoms. And we'll get to that in a few slides. Now, this is my favorite slide, and it shows you how naloxone itself works. And on the left, it shows you what an opioid overdose looks like. And to me, this looks like an ice cream cone with a scoop of ice cream. So your opioid is your ice cream itself, and it fits on this receptor in your brain, the cone, and ice cream takes a while for it to melt. Agree? But we all think that, well, we all have to kind of agree that ice cream is not truly healthy for us. So the healthier alternative is frozen yogurt. So looking at the right, how naloxone reverses an overdose is this frozen yogurt in the form of naloxone comes in and says, get out of here, ice cream. You're not healthy for me. Not like frozen yogurt's much healthier, but it aggressively competes for that same receptor and kicks the ice cream out of the way. And now it occupies this receptor site in the brain temporarily and allows the person to wake up and start breathing again. But continuing with my analogy of frozen yogurt and ice cream, in this heat or in this Phoenix area, which one is going to melt first? The frozen yogurt is. So the effect of naloxone wears off after a period of time, and the opioid is still present in the body and can reoccupy the receptor site in the brain or the ice cream cone. So let's refresh your memory, some of the things we need to know about naloxone. Specifically, it does not reverse any other overdose of any other medication except for an opiate. So if they've taken cocaine, methamphetamines, benzodiazepines in the form of Valium, Versed, Xanax, Klonopin, alcohol, this will not work on the effects of those drugs. And if a person is dependent upon opioids, like you find they have several patches all up and down their arms, by administering naloxone, you may produce withdrawal symptoms which are life-threatening. So they pound this home with you. They want to make sure you understand. If you see them take what looks to be Valium and you agree that it's Valium and they stop breathing, you can give them all of the naloxone you could find access to and it will not make them start breathing again. Same could be said for Ativan, for Xanax, for alcohol. It is not effective for cocaine or amphetamines. So if it's not going to work for you, I would not give it. But if you have reason to suspect that there is an opiate involved, you should give it. But I talked about those symptoms of opioid withdrawal, and I want to show them to you now. They include agitation, like the person wakes up immediately and they are agitated, and they have a very rapid heart rate. And they will have difficulty breathing because all of a sudden their lungs begin to fill with fluid. Sometimes they're nauseated, or they will begin to vomit and even projectile vomit. Occasionally they will have diarrhea, and even in worst case scenario, they will have seizures. The biggest problem is, as a healthcare professional, the only thing I can do is treat their symptoms and try and keep them alive, even once they've gotten to a hospital, until the effect of the naloxone wears off, and then they can go back to their opioid-dependent state, and they may not still have the tachycardia and the pulmonary edema or the fluid in the lungs. That is, if they survive that period of time. So, it is not a perfect drug, but it is as close to a perfect drug as we can find for reversing opioid overdoses. So now on this slide, you will see that naloxone, compared to other opioids that it works against, has a very short duration. Naloxone is the red bar on the top of the screen, but if you look at methadone, the effects of methadone will last for about 8 hours, where Narcan or naloxone is working for just about an hour to an hour and a half. Hydrocodone, codeine, oxycodone, and morphine all last for about 4 hours. So again, there's 2+ hours after the naloxone wears off where the person could have an overdose situation. And occasionally in the hospital, they have to be administered a second or third dose of naloxone. So the routes of administration that are approved for EMTs, law enforcement officers, bystanders, and school staff include intranasally and intramuscularly. But we're going to spend most of our time focusing on the intranasal approach because, as I mentioned, working with law enforcement, I don't like giving cops needles. And I don't think it's safe to put more needles out there anyways. So we're going to focus on the intranasal route. But as a paramedic and my friends who I work with in the hospital, the RNs and the physicians, we still have the option of giving it intranasally or intramuscularly or intravenously or interosseously into the bone or into a tube that goes into their throat to help breathe for them. But most of the time, we're just going to go back to the intranasal route. So the reason why intranasal is highly beneficial and highly attractive in this situation, because IV access might be difficult for a paramedic or a nurse to obtain on somebody who is abusing IV drugs. And when I have a needle out in my hand or another healthcare provider has a needle out, there's an increased risk of needle stick injuries and an increased risk for infectious disease exposures. But more importantly, the intranasal route is simple, fast, and convenient. So it works very quickly because your nasal mucosa has a very large absorptive area and it goes directly into the bloodstream. Not that this is always happening, but if you think about the short distance from your nose to your brain, it's a pretty short distance. So the nose is an easy access point for us to get the medication into the bloodstream, and it does work just as fast as me starting an IV, assembling my naloxone to put together, and then administering to the person. But at the end of this device this intranasal device is an atomizer. Basically, it makes a bunch of small particles so we can take advantage of that large absorptive area in the nasal mucosa. And the nice thing about it, it's painless for the person who's receiving it. So the benefits of the prepackaged spray, which I will show you, this is probably what you're going to be having access to. It is the Narcan nasal spray available from Adaptive Pharma. And you guys can read up on it, but it is very small. It can fit into a pocket. It can fit into a first aid kit. It should be in, and I'm not sure where Great Hearts is going to keep them, but it's pre-measured. And it's designed for self or for peer administration and for very easy use. So when you take it out of the package, you have this very small device like this. And what I can tell by looking at this is that this device has already been used. But it is so simple that I can just take this and put it into the tip of my nose, and I would depress the plunger if I had not already demonstrated that once before. So there's not a lot of fine motor skills or anything you have to assemble. There's very few challenges. So before we talk about how to do it, let's talk about when to use naloxone. And we have to suspect that there is an altered level of consciousness that includes respiratory depression or apnea. Basically, if the person is not breathing at least 10 times a minute, or if they're not breathing at all, or if they're only gasping, then we want to consider using naloxone. If they don't wake up to a painful stimuli, if you're pinching them here, if you're doing a sternal rub, and they don't respond in any way, and they're not breathing, we should probably think about administering naloxone. Also, signs and symptoms you might notice would be constricted pupils, profuse sweating. They might be blue or pale around their face especially, or you might notice needle tracks or marks somewhere on their body. So we talked about how you can get high on opioids and opiates and how that's technically okay in this setting. We're more concerned about addressing an overdose. So when somebody gets high from an opioid, their muscles become very relaxed. But when they've overdosed and they've crossed that threshold, they now have pale and clammy skin. If somebody's just high, they have slurred speech or it's slowed. But when they've overdosed, they aren't even talking and they're probably not breathing. If somebody's really high, they are sleepy looking. But if they've overdosed, they are snoring or gurgling and breathing their own vomit at this point or their own saliva. So they're not responding in any way or they're not interacting. Speaking of response to stimuli, if they're high, yeah, they'll respond to your shaking, yelling, or sternal rub, but they will be unresponsive to the shaking, yelling, and sternal rub if they've now crossed that threshold to an overdose. Really high people may have a normal heartbeat or pulse, but overdose people either have a slow pulse or an absent pulse. And lastly, high people have a normal skin tone, but overdose people have that bluish hue to their lips and their fingertips. So why should we suspect that there's an opioid overdose? First of all, if you recognize that there are drugs or unknown drugs found, or if you recognize what the medications are. Also, if you see drug paraphernalia like needles, syringes, spoons, or unknown devices. Another reason to suspect an opioid overdose is if somebody states, or a witness states, that the person was taking an opioid or a suspected opioid prior to their becoming unconscious. So here's a picture of some syringes and a vaping-style device in the middle, and lastly, a burnt spoon. To the right side of the screen is just pill bottles. Now, I don't always trust the labels that are on pill bottles, and I sometimes don't even trust how the pills themselves are stamped because of some of the counterfeit pills that are out there. Speaking of some counterfeit pills, this slide shows some fentanyl-related issues, and they include these little blue pills that are stamped M30, but these may or may not be fentanyl because the illicit or illegal drug industry does a really good job of mimicking the condoned drug industry. On the other side of this fentanyl-related slide is you see a person's leg with multiple fentanyl patches. So this kind of gives you an idea. Either this person was in a lot of pain or they have some addiction issues, because I count 6 patches and the residue from a 7th patch on their thigh on the right. We mentioned constricted pupils. On this slide, you see somebody's pinpoint pupil. It's like you're trying to thread the eye of a needle. About 1 millimeter in diameter is what they're estimating here. But if they're very, very small and very tight, this is a sign of an opioid overdose. On the second half of this page, you see someone here with a needle and a syringe beside them. I would suspect that they've overdosed based upon just seeing that needle and that syringe. They might be a diabetic. They might not, but I'm going to have a high index of suspicion if they don't respond, and they have constricted pupils, and they're not breathing, and I have Narcan to administer to them. So I mentioned one of the mimics of an opioid overdose is low blood sugar if they're a diabetic. But some other mimics include cardiac arrest. They could have respiratory or cardiac problems. They could have suffered a head injury. They could be experiencing stroke or a heat-related illness. They could be in shock from loss of fluid, whether it's from sweat, whether it's from GI contents, whether they've been vomiting and they haven't been able to keep food or fluids down, or from bleeding from an injury. And the last mimic that I'll mention is this hypoxia, this low oxygen state, which may cause somebody to act like they are overdosing on an opioid. But in these instances, if they have the respiratory depression and you have reason to suspect it, you will not harm them if you administer the naloxone and continue on with whatever treatment you need to. So, when are we going to give it again? That you suspect an overdose, and they have signs and symptoms of an overdose, and they are unconscious, and they are having troubles breathing. Because not everybody who's unconscious is an opioid overdose. So as I mentioned, they could be a diabetic. They could be just knocked out. We are talking about sports and athletics. And sometimes the dose of naloxone that you immediately have available is not going to be enough to reverse the opioid or the amount of opioid that they took. So here we have a simple sample algorithm as to when to use it. First of all, if we suspect an overdose and they are unresponsive to painful stimuli, and we assess their breathing status, and we go down the red section of this tree that they have no breathing or they are gasping, we want to administer naloxone and provide CPR. If we stay to the middle of this tree and you go to the blue section and they're breathing less than 10 times a minute, we want to administer naloxone. But if we go to the left side of this tree and they have a normal breathing or even fast breathing, we turn them on their side and we do not administer naloxone. There's no benefit to be gained for somebody who's already breathing adequately. Some things to consider, though, that you also want to do is you want to call 911 or activate your emergency response system. You want to call for 911 and have EMS come to wherever you are. Use caution because some people may have that opioid withdrawal with the nausea and vomiting and diarrhea and the combativeness. And this is why I tell you to roll the patient onto their side. And unless you want to be drenched with their vomit, I would suggest you roll them away from you. If you have a second dose available and the person is still unresponsive and not breathing adequately after about 3 to 5 minutes, you can consider giving a second dose. And this may happen in people who have recurrent respiratory depression or central nervous system depression because of the amount of narcotic or opioid that they took. Some other safety considerations: whenever possible, practice good body substance isolation by at least putting on a pair of gloves. Drug addicts, especially IV drug users, are at high risk for communicable diseases like hepatitis B, hepatitis C, and HIV. And because we're talking about sports, I always reference back to Magic Johnson, who looks terrific, but he's been HIV positive for almost 30 years, I'm estimating. So my message to you now is you cannot look at somebody and see if they have hepatitis B, hepatitis C, HIV, etc. It is common to encounter body fluids in these situations, so it is a good idea to have gloves available as a minimum in your first aid kit. But besides, some of the body fluids you might encounter would include the blood, the vomit, the saliva, the urine, the feces. These are all capable of transmitting diseases, so please protect yourself. And the reason why, if we find any needles, and why I don't give you needles, you do not want to come in contact with them, so you should never try to recap the needle if you encounter one. Place it somewhere safe, take a book or take a large bag, or if you have a water bottle or something else, place it over top of it, and when EMS arrives on scene, have them dispose of that needle for you. If for some reason, and again this says kept as evidence because this is the AZ Post presentation, they want you to put it in a puncture-proof can. Either way, put it in a water bottle, do not recap it, and whenever possible, minimize the handling of it. Here's another algorithm that you guys can cut and paste and adapt. But basically, if the person is responsive and breathing adequately, then we continue to monitor them and we wait for help to arrive. However, if they're not breathing adequately, then we want to do a sternal rub. And if it gets a response, then we're going to continue to observe them. But the longest portion of this algorithm, if they're not breathing adequately, then we want to consider starting CPR and administering Narcan simultaneously. So it is important for us to recognize the potential for opioid overdose with the decreased level of consciousness and the poor breathing and the opioid setting itself. The sternal rub, which we've talked about, creates a very raw spot on their chest, so you can also do like pressure points and noxious stimuli, etc. But administer the naloxone if they are not adequately breathing and place them in the recovery position. Here's where you are trying to access with this slide on the sternal rub. It's the bone in the center of your chest where we place our hands for CPR, but in this case we're going up and down this way, not up and down this way. The recovery position, you see how you just take the person's arm on this slide, and she chooses to roll them towards herself, but again, I roll them away, and I take their top leg and I bend it so that they don't roll all the way onto their stomach. But this should be a very common position from your first aid and CPR classes. So we're going to talk about the actual dose or the amount of naloxone that we're going to give. And the good news is, because the only complication of naloxone administration is that withdrawal syndrome, we can give high amounts of naloxone to adult doses, essentially, to small children if we had to. So I'll briefly talk about the auto-injector, which you will probably not have, but if this is something you end up getting, I can come back with a shorter video and demonstrate this for you a little bit more. But the auto-injector has 0.4 milligrams in the intramuscular dose, and that can be repeated every 2 to 4 minutes if you have a second one. But we're going to focus on the naloxone intranasal spray. And there's one setup out there that allows you to use what is issued to me as a paramedic or as an EMT or a nurse, this two-piece connection and an accessory device that allows for the medication to go to be atomized and inserted into the person's nose. But I'm not going to spend a whole lot of time with that because you will have the prepackaged dose. And as you look at your prepackaged dose, it will tell you that there are 4 milligrams in here. So we're giving them 4 milligrams in our intranasal dose, which is just fine. The next slide shows the intranasal options. One has the pre-filled, and then I call it the Lego kit, the Lego Narcan kit, because you have to assemble it and put all the pieces and parts together. But here's what we're doing. This shows you the nasal passages again. It's going to look like the ice cream on the cone again. And on the other side of the page, you will see how we're putting just the tip of this atomizing device inside the nostril. We are not trying to go deep into the nose. We are going just inside the tip of the nose. And then you have the small parts or particles that come out that have now been atomized when you depress the plunger. So the prepackaged, what you're going to do is you will take your prepackaged dose, you will remove the foil backing. It's usually at the top here. So I will open this up, and just in case I forgot my instructions, you can actually take your instructions out in the emergency and read them if you choose to. But it is available for you to go through. But now we're going to take the tip of the plunger, okay, we're going to take the tip of the device into the patient's nose, and we're going to depress the plunger on the underside. I move to the next slide, which shows how it creates a mist. What I could do is administer it to myself, but I'll just do it for demonstration purposes. You'll see me depressing the plunger just inside the tip of my nose, and you have a spray that just popped out. There are slides available that we will go through very quickly because you're not going to use the mucosal atomizer device, but I will show you, in essence, anything that has 6 steps to try and save somebody's life is not very cost efficient or very timely. So you have caps that you're taking off, you have another cap that you're taking off, you're assembling something, you're taking off another cap, and you're putting a third device on there to, in essence, do the same thing. And you get the same spray out of here. So this is why we're going to stick with the already assembled prepackaged device. There's a few slides in here about the auto-injector. I did not have a demonstration model for it. This is the eVisio auto-injector for naloxone. If this is something you guys are going to get, I will come back and do a demonstration with it. But in essence, it is like using an EpiPen auto-injector. So you do whatever safeguards you have from your EpiPen training. If you have not had it, we can go through that at another time. You take off your rear safety guard, okay? Don't touch the end that's supposed to be the needle. I advocate that you take where the patient's hand comes down and contacts their leg, okay, where their palm hits the front side of their leg, not here, not on the side, but kind of on that 45. And you are going to, with your hand, wherever that hits, you are going to take the device, you are going to push it in, you hear that little click. I want you to count to 10 because I know you're going to count to 5 way too fast. And that gives the plunger on the inside time to push all of the medication in. And then what will happen is you will have your spent auto-injector device, which you will then give to EMS when they arrive because there is a needle. Typically, though, the needle is not exposed, and that's just fine. But again, there is a sharp that's in there. So I'm progressing through some slides. You notice that I did this right through my clothing, and you would do this right through somebody's clothing. The only thing you'd want to do is make sure you did not encounter anything in their pocket. Okay, so it does not do you any good to administer naloxone in an auto-injector to their keys or their cell phone or their wallet. I mentioned that children might be susceptible to overdose, and even though we've got the same needle auto-injector or the same nasal spray, the only thing that we do differently with infants if we're using the auto-injector is we're probably going to chunk up their little thighs and create a little bit more meat so that that needle that is a certain length does not drive down into their bone. We want it to go into the musculature, if you will. But again, adult doses, we can give them the same 4 milligrams of naloxone or 0.4 milligrams auto-injector, whatever else. But do not try and put anything back together with the auto-injector if you have it. Usually it will tell you that it's been used. So now that we've given naloxone one way or the other, okay, we've probably given them the prepackaged nasal spray. What you need to ask yourself is, are they still unconscious? Do they still have a pulse? Do we need to continue doing CPR? If they still have a pulse, we want you to roll them into the recovery position and continue to feel for a pulse and observe them for signs of waking up. However, if you cannot feel a pulse or if you're not sure, we want you to start doing CPR right away, especially if you are trained. You may choose to do rescue breathing if necessary, but I would advocate that you use some sort of PPE, personal protective equipment, and some sort of barrier device as you're trying to breathe into somebody else's mouth, because most likely they could start to vomit or have diarrhea or other agitation. After what might feel like an eternity of 3 to 5 minutes, if fire department, law enforcement, EMS are still not there, and a second dose of Narcan is available, and they're still not breathing adequately, you can consider giving a second dose, okay? But then ultimately the goal is for them to be transported to the hospital by EMS. So let's go through the steps of how we're going to address an opioid overdose. We're going to start by recognizing the emergency. We're going to do a sternal rub because we have a high index of suspicion for an opioid overdose. We're going to simultaneously call 911 or whatever our emergency response procedure is. We're going to start CPR if they're not breathing and you can't feel a pulse while somebody goes to retrieve the naloxone. When it does become available and they're still not breathing adequately, you administer it through whatever route it's intended, and then repeat steps 3 and 4, the CPR and the administration of naloxone, and as necessary until something changes, until fire or EMS and law enforcement show up, until the person wakes up. And if at some point you see them breathing on their own, roll them into the recovery position, preferably rolling away from you. So these signs of improvement, what are we looking for? That their breathing starts to return. If it was gasping or very shallow breathing, that their breathing becomes deeper and more efficient. For their circulation, that the quality of their pulse or the color of their skin goes back to normal, that their pulse pressure or pulse quality is stronger, that their consciousness or their level of alertness becomes markedly improved. So these are all signs of improvement, and therefore we don't have to give them any more if this is what's happening. Now, law enforcement and EMS have to document their use of it, and I think it's a great idea for schools and school staff and coaches to document the use as well. There is a form available from the state of Arizona that allows you to report back on the use of it so that we can refine the education, we can refine the administration of naloxone so that we can continue to get grant funding for this epidemic. Some special considerations, though. The benefit of the school is these are all minors. However, if you work with other athletes that are in college, once the person is alert and oriented, they cannot be forced to go to the hospital. Sometimes law enforcement has some challenges with this, but alert and oriented means that they can answer questions such as who they are, where they are, and the circumstances surrounding the incident and perhaps what time or day it is. But if they can refuse, technically they're allowed to. However, for your minor students or minor athletes that you have here, you are probably going to work under their parents' consent. So, to summarize what we've gone over before we get into a few different examples, naloxone is a safe and effective drug for treating opioid overdoses alone, and it will help to lessen the lethality of overdoses by getting naloxone to scenes faster if we are issuing it to law enforcement, school nurses, to coaches, and to family members of addicts. But we do want you to ensure that the emergency response system, or 911, is activated. It's only one part on that chain, and we need the whole chain to be completed for the person to have the best outcome. So you can start by giving them Narcan, but if you forget to call 911, they're never going to get the treatment that they need. But we do want you to also follow your organizational guidelines for your response to suspected overdoses. So if Great Hearts has a different policy that does not stay according to AZ Post or AZDHS, then your lawyers and attorneys have reviewed that and they've decided it is better to do it their way. So I'm going to take just a short minute before we get into some 5 different scenarios to test your knowledge application, because I probably won't be in the classroom with you with all of my little toys to demonstrate with you, but I did want to show you that these devices that look similar to my used live device, this is my demonstration device, and I can tell this because, first of all, the plunger is down. Second of all, it's got yellow labels all around it. But for all intents and purposes, it's the same thing. So if you have an opportunity, you can use mannequins, etc., to use these training devices, because what you see is this plunger comes back down. Normally, if I'm doing this in the classroom with you or with a group, I have people hold this up and press the plunger if they think this is an appropriate circumstance to give naloxone for the scene that I'm describing. So I have 5 little vignettes for you, and we'll kind of read through these, and I'll give you a moment to answer these questions yourself. So shortly before the beginning of a practice, an athlete informs you another athlete was acting strangely and then put their head down on a bench and now won't wake up. Upon your arrival, the athlete is not moving and has bluish-gray lips. The athlete is placed on the ground and does not appear to be breathing. So the first question I ask you, is this a possible opioid overdose? And the second question that I ask you, if you think this is an opioid overdose, what are your next 3 steps? Insert Jeopardy music here, please. So yes, this is a possible overdose. So your first step is to ensure that 911 has been called and that a staff member is prepared to direct fire, EMS, or law enforcement to the appropriate location. If they're not breathing and they don't appear to be breathing and you can't feel a pulse, we want you to begin CPR or CCR if that's what you're practicing. That's the continuous chest compressions. And if you don't have it readily available, then we want you to send someone to get the AED and the naloxone. So if you keep them side by side, you have naloxone in with your AED, that is actually probably a good plan because sometimes they go hand in hand. And if you have both of those things next to your bleeding control kit, I think you have a pretty good first aid station right there. So, yes, this is a possible overdose. Call 911, start CPR, and get your equipment needed to treat it, the AED and the naloxone. Now, I have a trick question for you. In which nostril do you administer the naloxone? I'll let you think about that for a minute, because I have a bonus question. Do you stop CPR or CCR to administer the naloxone? So the answer to your trick question, it does not matter, okay? Whichever nostril is closest to you, easiest access to you, least obstructed, maybe doesn't have a nose ring or something else in it. The bonus question, no, we don't stop CPR while somebody else is administering the naloxone. It actually helps to have the naloxone go in while CPR is being conducted. Vignette number 2. An athlete is caught in the bathroom after ingesting unknown pills. The athlete is hallucinating and is otherwise inconsolable. Meanwhile, they are sweating and breathing at least 20 times a minute. So there's 5 pills in this person's hand. This is what's left over after they take the rest of the handful. My question to you is, should naloxone be administered to this patient? I give you a moment to think. No, the person should not receive naloxone. They are awake. They are not showing any signs of inadequate respirations. Does this mean we shouldn't call 911? We should still call 911. The parents should still be contacted. This is more of a disciplinary problem, but it does not warrant the naloxone being administered. We would continue to observe this person for any changes in case they did start to have signs of an overdose where they would stop breathing. Good. Vignette number 3, moving right along. After halftime, and I'm just picking a sport that has a halftime, an athlete is complaining of not feeling well. They appear lethargic, uncoordinated, and they are slurring their words. They are also pale and diaphoretic or sweaty in their appearance. They're breathing about 12 times a minute, but without any increased effort or distress. So, based upon their not feeling well, slurred words, pale, and diaphoretic, should naloxone be administered to this athlete? Give you a minute to think. Hopefully you're thinking, no, it should not be administered to this athlete because they're not showing you any signs of an overdose on an opiate. Your other differentials, what could be going on? They could be reacting to a prescription medication. They could be having a diabetic-related issue. It could be a head injury or a seizure. It may be an other medical issue like a heat exhaustion or heat stroke, heat cramps. Or they might just be high, but as long as they're breathing, they are not overdosing. As long as they're breathing adequately, they are not overdosing. So let's move on to vignette number 4. An athlete was caught vaping by another athletic staff member. The athlete begins to cry immediately, but then over a period of a few minutes, they become more somnolent. They are difficult to wake up. While waiting for the athlete's parents, they won't wake up, and now their breathing is very shallow and irregular. So my question to you is this athlete possibly experiencing an opioid overdose from this vaping device? And my follow-up question to that is, if you do think they are overdosing, what are your next 3 steps? So I gave you a moment to think, kind of formulate a plan. Yes, there is a potential for them to be overdosing. So just like in our first vignette, we want to have someone call 911 and activate emergency response system, probably retrieve the naloxone or the Narcan, place them on their back at this point or in the recovery position, and if they still have a pulse, be prepared to administer CPR when they do not have a pulse, but do administer the naloxone whenever it becomes available. So I have some follow-up questions since we all kind of agree that this is a situation where naloxone should be administered. Where do you put the tip of the naloxone spray in relation to the nostril that you are choosing? So as you're thinking about that, my follow-up question on this slide, how much of the naloxone in the prepackaged spray should be administered? The tip of the naloxone spray should be just inside the opening of the nose. As you can see, my finger is in my nose, but my fingertip has not disappeared. And then to answer the second question, you're giving the whole package. You cannot titrate how much in this little dose. You're like, no, it's one shot and it's done. Our last vignette, the piece de resistance, the grand finale, if you will. As you are walking out of the locker room, you turn the corner and you see an athlete laying face down. The scene is safe for you to approach. The athlete is unresponsive to painful stimuli and is only exhibiting occasional gasps. Name 2 ways, because I thought of 4 immediately, that you could summon help or assistance. How could you call for help if it's just you in the middle of a hallway outside of a locker room? Of course, everyone's probably got at least one cell phone on them, but you could also start knocking on doors, you could start calling for help, or coach, use your whistle, and start blowing your whistle because that might get people's attention. Either way, you've got numerous ways you can call for assistance. So you summon help, and when somebody comes to your aid, you remind them to get the AED at the same time. Because they are agonal, they're not breathing, they don't have a pulse, you begin CPR or CCR as necessary. When the AED arrives, you lift up the athlete's shirt to apply the AED pads as you've been trained, and you notice several medication patches on their chest. It will look like this slide here. So, you see these patches, and I go back a slide. What is your next step in regards to those patches as the AED comes available? So hopefully you're sitting there thinking, well, I probably need to take those off. But why? There are 2 reasons why we need to take those fentanyl patches off of the person's chest. The first reason is it could be causing them to have an overdose, and we could help ourselves with the problem later. The second reason is, where do those AED pads go? Probably in the same spot as one of these patches, but regardless, you always want to remove any medication patches before applying an AED pad because of the energy that's about to be delivered. So, you've removed the medication patches with gloved hands, and you apply the AED pads. The AED says no shock advised. No shock advised. You can't use it to defibrillate them. So if it says no shock advised and the patient's not moving, what should you do next? Start CPR, right? Start CPR. Terrific. So you've resumed CPR, and my second question is, what's the second action you should take? Probably switching compressors, or whoever just showed up could administer that naloxone if it's available, but if you haven't already. So now we've resumed CPR and administered at least one dose of naloxone, and the AED tells you to stop CPR, analyzing heart rhythm. And you notice that the patient has started to breathe on their own, and you feel that they have a pulse if you are trained and feel comfortable with that. The patient is breathing about 16 times a minute, but they're still minimally responsive to painful stimuli, and when you open up their eyes, they still have pinpoint pupils. So the big question is, should another dose of naloxone be administered at this point? Hopefully, you keyed in on the fact that they are breathing on their own, and we do not need to give them another dose of naloxone. So, congratulations. You've hopefully passed our little quiz for our application of knowledge on when and when not to give naloxone. And I just want to close with a few slides on, are we winning this war on opioids? Okay, this is something that has been around. It's been a national crisis. The governor made a statement or executive order addressing the opioid epidemic in Arizona. And if we look at some statistics from a few years ago, there are some improvements in or decreases in the opioid deaths. And there's three different things that are happening here that we can attribute the success to, especially in Arizona. We are increasing the training and the availability of naloxone and Narcan. We're pressing it out to bystanders and first responders in non-traditional roles, like putting it into the hands of school nurses and school athletic coaches. But we're also increasing the awareness for responsible opioid prescription practices. If you are a physician or about to become a physician in the state of Arizona, they are really emphasizing wise and intelligent prescription practices, not writing people for 3 months' worth of opiates and then not following up with them. So they're doing different prescription practices, 3 days' worth, 4 days' worth, and then they have to follow up, which decreases the addiction and abuse potential. The last thing that Arizona is doing is they're increasing the availability and funding for addiction programming. How to help these people, because addiction is a medical condition, and by prescribing a legitimate prescription of an opioid for somebody who has an addiction issue, we're not helping them. So we're trying to find ways to help people deal with their addiction. So we have increased rehab centers and increased funding for them. At the bottom of this page is a hyperlink that will take you to the Arizona Department of Health's homepage with up-to-date information on opioid and the opioid epidemic. So they update it weekly with how many doses of naloxone have been issued, how many doses have been used by law enforcement, how many prescriptions have been written by physicians, how many deaths we've had, etc. And it's actually very informative. You can go through and see what happens county by county, by different demographics, etc. My last few slides are several different hyperlinks, which hopefully work for you if you get the actual presentation. The Governor's Department on opioids, Health and Human Services, the School Nurses Association, the CDC, the AMA, some ripped from the headlines news stories that I think are important for all of you to have access to, some frequently asked questions, and some recent EMS-related articles. So it's good conversation starters for the athletes that you are responsible for, or if you have children, you can go over some of this information. None of it is inappropriate for middle schoolers, even elementary schoolers, and it certainly should be something that we talk about with our high school athletes and scholars. So I thank you very much for this opportunity to share this information with you. If you have follow-up questions that were not addressed, I would encourage you to go back through. I'm going to throw Jonathan Rickey under the bus here and have him email me so that I can address your specific questions. So thank you very much.
Thank you, Tim. Please feel free to contact your athletic director if you have any questions based on the training of opioids that we just had. Thank you again for your time today. I believe there is not a more influential adult in the lives of our students other than their parents than our coaches. The influence that you have is great. Let's continue to focus on making great people first and great athletes second. I hope to see you on the court, course, or field very soon. Thank you, and have a great season.